All right, welcome to this explainer. We've designed this to be a really high-yield review of what you absolutely need to know for your anesthesia finals. We're going to be focusing on the critical management of heart and lung transplant patients, covering everything from referral all the way through to recovery.
So, let's just start with the scale of the problem here. To really understand why transplantation is so crucial, you have to get your head around the sheer number of people affected. Globally, we're talking about over 26 million people suffering from heart failure. That creates this massive and frankly growing need for advanced therapies.
But get this, despite that huge number, only about 9,000 heart and lung transplants are actually performed each year. It's a stark contrast, right? And it really highlights the critical donor shortage we're facing. It also underscores just how high the stakes are for every single one of these procedures. It means there's just zero room for error.
So, we're going to follow the anesthetist journey from patient selection, through the surgery itself, and all the way to managing those long-term complications. This structure should really walk us through all the key decision points. Okay, let's dive right in. First things first, who even gets a transplant? The selection process is incredibly rigorous, and getting this part right, well, it's one of the biggest factors that determines whether we have a successful outcome or not.
Now, this slide breaks down the key reasons for a transplant. And for your exams, you absolutely have to know the difference between absolute and relative indications. So the absolute ones, like refractory cardiogenic shock, these are life or death emergencies where nothing else is working. The relative indications, though, like a peak VO2 below 14, they represent a quality of life that is just so severely limited that a transplant becomes a very strong option.
And just as important for your exam are the things that rule a patient out. The absolute no-goes, like a recent cancer. They're pretty straightforward. But you really need to pay attention to this one. Severe, irreversible pulmonary hypertension. This is critical because, as we're about to see, it can cause that brand new donor heart to fail, like immediately. It just makes the whole procedure far too risky.
Okay, let's move into the preoperative phase. This is all about how we prepare these incredibly fragile patients. Meticulous assessment and optimization here can truly make all the difference.
So we run a whole battery of tests on these patients. But if you're the anesthesist, the single most critical investigation, the one you're laser focused on, is the right heart catheterization. And this isn't just about getting some pressure readings. It's about understanding the entire pulmonary circulation and predicting how it's going to react to a new heart.
Okay, so let's get into the nitty-gritty of what really matters here. Pulmonary vascular resistance, or PVR. Think of it like this. A donor heart comes from a healthy person, so its right ventricle is used to an easy job. It's untrained for heavy lifting. If you suddenly force that ventricle to pump against a super high-resistance system in the recipient's lungs, it can fail, just catastrophically. We measure this PVR in Wood units. Normal is less than 1.6, so when we see numbers way higher than that, we know we're in a high-risk situation. A PVR over 3 Wood units? That's a major red flag. And if that high resistance doesn't come down when we give drugs to open up the lung vessels, well, that patient is at extremely high risk. Often, the only way forward is intensive medical therapy or even putting in a left ventricular assist device, an LVAD. That's a mechanical pump that acts as a bridge to transplant, giving the circulation time to rest and hopefully lowering that PVR.
All right, now we're in the operating room. This really is the anesthetist high-wire act. Every single decision you make has immediate and profound consequences.
Let me be clear, induction is probably the single most dangerous moment for these patients. They have virtually no physiologic reserve left. So this protocol is all about managing that insane hemodynamic instability. Notice the emphasis here. Get your access before you start, go slow, and have those vasopressors drawn up and ready to go.
Now, for lung transplants, you hit this big fork in the road. Do you use cardiopulmonary bypass, CPB, or not? And this just perfectly illustrates the kind of trade-offs we're constantly making. Using the heart-lung machine gives you ultimate control, but staying off bypass avoids that huge inflammatory response and all the bleeding problems the circuit can cause. It's a tough call.
And the whole time, the clock is just ticking, relentlessly. From the second the donor heart stops beating until it's reperfused in the new body, it's getting damaged. We call this ischemic time, and every single minute of it impacts how well the new heart works, and ultimately whether the patient survives. So keeping it under 4 hours is the absolute goal.
This is where new technologies like the organ care system, or what people call the heart in a box, are just complete game changers. Think about it. Instead of the old school cooler with a heart on ice, the OCS keeps the organ warm, beating, and fed with blood outside the body. This could dramatically reduce that ischemic damage and maybe extend transport times from 4 hours to 10 or more. That would just massively expand the number of donors we could use.
Okay, here it is, the moment of truth, the most anticipated part of the whole operation, waking up the new organ. This is when we restore blood flow and we finally get to see if this new graft is going to work on its own. And this is a non-negotiable step. You cannot rush this. You have to give that new heart a minimum of 1 hour to recover and stabilize while it's still getting full support from the bypass machine. It's one of the most critical parts of the whole surgery. And in fact, as the Jernred study showed us, if that ischemic time was long, pushing that reperfusion period to over 90 minutes actually improves survival.
Now, for your exams, this is a core concept you have got to understand. The transplanted heart is neurologically disconnected. The wires have been cut. It has no nerve input. What does that mean? It means its cardiac output is now entirely dependent on preload, how much blood we fill it with. So forget about using drugs like atropine or ephedrine. They're just not going to work. It will only respond to direct-acting drugs like adrenaline, and even then the response is often kind of slow and blunted.
So what's the biggest hurdle right after reperfusion? It's right ventricular failure. That untrained donor RV is suddenly staring down the barrel of the recipient's high PVR. Our management is a three-part strategy. We carefully optimize the preload. We use drugs like inhaled nitric oxide to drop that PVR. And we give direct inotropic support with things like adrenaline or milrinone to help the heart squeeze.
So the surgery's done, but believe me, we are far from out of the woods. The work continues, and the challenges just keep coming in the ICU and, really, for the rest of the patient's life.
Primary graft dysfunction, or PGD, is without a doubt the most feared early complication. It's basically the new organ failing right out of the gate. And it can affect up to 1/3 of patients. Think about that, 1 in 3. And it is, by far, the most common reason patients die in that early postoperative period.
And this table here is pure gold for your exams. It breaks down exactly what puts a patient at risk for PGD. You can see the factors fall into 3 buckets. Things about the donor, like a long ischemic time, things about the recipient, like it being a reoperation, and things that happen during the procedure itself, like massive blood transfusions. Knowing these helps you see trouble coming.
So how do we handle PGD? Well, it's all about support. We use lung protective ventilation. We use inhaled nitric oxide, or INO, to lower that PVR, and we're very careful with fluids. But here's the real take-home message for the severe cases. Have a very low threshold for starting mechanical support. Putting a patient on VA ECMO early, that can be absolutely life-saving. It buys the new graft time to recover.
This explainer was based on 2 fantastic articles, Cardiopulmonary Transplantation, an Anesthesia Review from the BJA 2023, and Anesthesia for Heart Transplantation from BJA Education 2021. And as we wrap up, you have to think about the future. The fundamental problem hasn't changed. Demand just crushes supply. So what's the next frontier? Is it going to be better machines, new tech like the OCS, or something that sounds like science fiction, like xenotransplantation? That is the challenge for the next generation to solve.